Hello, my name is Katie Hannant and I am a respiratory nurse by trade. I work at Frimley and I also am the CYP lead for the ICB for children's respiratory. And my role is part of the asthma bundle of care, which was started in 2021, and it was really to accelerate asthma care as much as we could do. We knew that with the NRAD study, which was over 10 years ago now, or 10 years ago this year, we knew that two-thirds of all asthma deaths were preventable, and this is for children as well. And actually, the asthma death rate hasn't changed considerably since in the last 10 years. So the asthma bundle of care is really an initiative designed to accelerate asthma care throughout England. And as part of it, it's really ensuring that clinicians are aware of when they're seeing children with asthma to treat them chronically rather than acutely, and to always have in the back of your mind, what has this child done? Has this child has an asthma attack previously? One of the main changes this year with NHS England is that they've done lots of things, but they've actually released a pathway for preschool wheeze. So this is, we know that obviously I think it's 80% of children under the age of 5 get a blue inhaler at some point. And we know that children's airways under the age of 5 are immature. So when they get a cough or a cold, they do wheeze. So they're given this blue inhaler, and this is where the confusion with asthma starts. So whether or not those parents think that their child has asthma and they don't, or if the parents don't think that their child has asthma and they do. So it's really trying to pinpoint and actually diagnose those children who we do think are asthmatic, especially in this age group. So the preschool wheeze is designed from the ages of 1 to 5. So it's not including the babies who are bronchiolitic. So from the ages of 1, if you've got a child who comes into hospital with a viral wheeze, we know that historically these parents, especially when the child is asthmatic, so more problematic in this age group, with wheezing and respiratory issues, we know that parents often felt that they were quite lost within this age group. They didn't get a lot of help, and they may have presented to hospital quite a few times, but they weren't given any real guidance on what they should do. So NHS England have come up with this pathway to really improve that sort of aspect of respiratory health in children. So we know that when children, and we're talking about children with respiratory issues, they're coded as lots of different things. So we're trying to kind of like make children be coded into these 3 different boxes. So they either come in with viral wheeze, they either come in with episodic viral wheeze. So your viral wheezers are the ones who only wheeze when they get a cough or a cold. Your episodic viral wheezers may be the ones who are a bit more problematic, maybe having wheezes more regularly, and they may have some type of other issues going on as well, like atopy, or they are the ones who may not hit hospital, but they are more problematic than your normal viral wheezers. And then you have the children who are suspected asthma. So these are the children who may hit hospital, or who may have more symptoms, not interval symptoms. So they have symptoms in between having a cough and a cold as well. And they may have different allergies as well, presenting as well. So the pathway for the preschool wheezers is that basically if you have a child who comes in to hospital with 3 or more episodes of viral wheeze, then they would be diagnosed as suspected asthma between the ages of 1 to 5. And if they come in with a life-threatening viral wheeze attack, then, or they need PICU or HDU, and it's a more of a severe episode, then they would also be diagnosed as suspected asthma between the ages of 1 to 5. And the idea being is that we see these children more regularly. They're seen every 6 months. If we can do their formal testing over the age of 5, then brilliant, and we can give them a definitive diagnosis, hopefully. But actually, if we can't get them that diagnosis and they can't do those formal testing, then they stay on that suspected asthma pathway, and they're seen regularly, and they're given education about what asthma is and what their inhalers are doing. They can move in between these pathways. So if you get a child who's diagnosed as suspected asthma, but then doesn't have any other symptoms, and you see them and they're absolutely fine, then they can go back to the viral wheeze coding as well. This is a really short video. It's a really sad video on a lovely little girl called Olivia. And this is kind of like what we see in asthma care for children and young people. She had an episode of viral wheeze. She was given a blue inhaler. So the parents carried on treating her with that blue inhaler. And that's the only time that we would say to give a SABA alone, is if you have a child with a viral wheeze. If as soon as they're suspected asthma, or you're suspecting asthma, then they should be given an ICS as well, and they should be coded as suspected asthma. But what we're seeing, and what we have seen a lot historically within England, is that children are given that blue inhaler and then not much else. So they carry on using that blue inhaler, and their symptoms obviously increase. This is a child who she sadly died when she was 10 years old. Olivia had been really well. She had had a few symptoms with her asthma, like we know, episodic symptoms. And we know that children and young people's, and also adults' asthma, it doesn't stay the same every day. We have episodes when your asthma's worse. And so it varies, and it is episodic. So just before she died, she was given ICS, and but no one explained to her what the ICS was for, and the mum said that no one had ever mentioned asthma to them, and she sadly died from an asthma attack. And let me play the video, and then we will catch up after.
Bubbly, cheerful, stretchy, and
mischievous.
She used to enter a room doing a cartwheel.
She was really good at gymnastics, and she used to win lots of competitions and things.
Always on the go, never sat still, so that was Olivia. That morning it was Red Nose Day, and she'd had a lot of involvement at school. I picked Olivia up that afternoon.
She was lagging behind me, wasn't she?
Yeah, I was talking to Max, and she was kind of slightly behind us. She just said that she'd had a tough day and been coughing. She came home, made us something to eat.
And that's when we said, I think you should go to bed, you're really tired.
When I went into her room, she was on all fours and on the bed. Her breathing was laboured. And I just said to her, just stay where you are, Ra. I'm going to go and put your medication in my bag. We need to go to the hospital. I remember looking up to the top of the stairs, and she was standing at the top of the stairs.
And then that's when I noticed her lips were blue. And then she just passed out in my arms, and then that's when we put her on the floor to try and
perform CPR.
But nothing was working.
I paced up and down the drive waiting for him to come, and then Lee and I went in the ambulance with her, but I kind of knew, really, that something, because her feet were yellow.
So, a terribly sad video, and a lovely girl who sadly died from asthma. And one of the take-home things that I find is that looking at that picture of Olivia on the day that she died, she looked really well, and that's what we say to clinicians as well, that when you're presented with a child in primary care or secondary care, and the parents are saying they've been up all night coughing, and when you see them, they might look very well. Really be aware of actually listening to the parents and listening to what they say, because actually, you know, we know that children do bounce back very quickly, and you know, they may have those asthma symptoms that actually might just be incorporated as part of that child. So making sure that you know, looking at their nocturnal symptoms, are they coughing at night? How well are they keeping up with their peers when they're running around the playground? Are they able to keep up with their peers, you know, or are they having to stop, and are they having to get more you know, take longer to recover? So things like that we really need to be aware of, and really looking at these children as a chronic condition rather than an acute condition. Have they had a previous asthma attack in the last year? So and was that asthma attack severe? Because if you've had a severe asthma attack, then you've got a lifelong risk of having another one. So going back to these preschool wheeze, so we know that this is all the red flags that we want to look out for in those age group between 1 to 5, and hopefully if we capture the children who are more problematic, then those will be the children who are suspected asthma, diagnose them as suspected asthma, and do the formal testing when we can. And then at least we will be starting that education off as early as possible with those parents to recognise those asthma symptoms when they flare up, and recognise those early asthma warnings. And also I will be going into some of the searches that you can do in practices for the potential children who may have asthma attacks. This is the salbutamol weaning. We've got a new salbutamol weaning regime in secondary care, and so this is really to move away from that blanket of those 3-day weaning regimes that we used to do in secondary care. And we would be given children potentially on the first day of going home, where they would be given 10 puffs every 4 hours, you know, up to 60 puffs of salbutamol. And so we know that those high risk of that high use of SABA is indicative of those asthma deaths. So really getting away from teaching parents that is normal to give that, you know, those high doses of SABA, which we don't want parents to do. So with this new weaning regime, we want children to have parents to be you know, looking at their child and deciding, you know, teaching the parents what they're looking out for. Are their children short of breath? Can they speak in a full sentence? Are they able to run around? Are they able to do their daily activities that they want to? If they need some SABA, to give 2 puffs via a spacer, and then wait between 2 and 10 minutes, see how they get on. And then if they need another 2, then they can have another 2 puffs. And if they need another 2, up to 6 puffs of the salbutamol, the SABA. So that's what we teach children and parents now as they're being discharged from hospital. If they need 10 puffs, then that's absolutely fine. But the ethos behind this weaning regime now is that the children should be improving. If they're needing 10 puffs every 4 hours, then they should be in hospital. Then they're not well enough to go home. So it's really teaching parents that actually we want your child to be improving. And this is where the 48-hour review comes into its own, because we want to make sure that that child who may have had oral or probably would have had oral steroids when they've come into hospital, are those steroids working? Is the attack over? And if it's not over, then going back to hospital and getting more treatment. And that's what we don't want children having asthma attacks at home, obviously. This is the Beat Asthma preschool wheeze plan. So you can find this on the Beat Asthma website, and you can download it. You just have to search for primary care resources on the Beat Asthma website. And this is a really good plan to give to parents if their child is between the ages of 1 to 5 and they have got preschool wheeze. And it's very similar to the pediatric asthma action plan, but it just doesn't mention asthma. It just mentions wheeze and what it is and what to look out for. This is the QR code that will take you to the Beat Asthma resources, and this has got all you need to actually give to parents and lots of information that you can give to parents when they come in with preschool wheeze. There's also the guidelines. This is actually just changed this week. We've been long awaited guidelines for BTS NICE. They've now amalgamated, and it was meant to come out last year, but it's finally come out this week as a consultation. So it's only until July for the consultation, but it is actually, sorry, that writing's really small. I didn't realise it was so small. I've added this slide in. But one of the main changes that they're looking at for diagnosing asthma is abnormal spirometry, and also doing blood eosinophils and seeing if they're raised, and also a pheno. Now, I don't know how easy that's going to be for primary care, but please have a look at the guidelines. And as I say, it's a consultation, so do reply to the consultation before the end of July. We know that with pheno, now every PCN in Frimley does have access to a pheno machine. The ICB since July this year has increased the funding up to £20 per test for pheno to help pay for the sensors, because I know that that was a issue initially once everyone had got their pheno machines. We know that spirometry, especially for children, is still sporadic around Frimley. And what we are doing, I have got 10 spaces on a paediatric spirometry course, which will come out shortly, that the ICB have funded. There are also, if you go on NHS Futures, there's a lot of free courses for spirometry on the NHS Futures page, which are actually really good. I watched one and it was really interesting. Secondary care, the team at secondary care won't just do spirometry and won't just do diagnostics, but they will see children, and I'll go into the pathway for seeing children in secondary care as well. This is the new formulary that we have that was released, I think, at the beginning of this year now from the Meds management team. And this is for children and young people who have got asthma. So this is the new formulary between the ages of 5 to 12. It says anyone on an MDI, the children in this age group will usually have an MDI. I mean, you know, the greener spacers inhalers are there, but actually for this age group, it's mainly MDIs. You'd have to be really careful to make sure that a child could take a dry powdered device and do in-check tests and everything to make sure they had enough inspiratory strength to actually take the dry powdered devices, although they are licensed from 6. But usually in this age group, we have the MDI spacers. So if you have a child with suspected asthma or asthma, they should not be just on a SABA alone. They should also be on an ICS. And you can give Symbicort, so you can give ICS for Meteorol. That is the, well, actually, only until recently, that was the only combined inhaler that was licensed for children over the age of 6. But we since have, I think since April or May, we have had Spiromax as well, that is now licensed for MART regimes as well. But we don't recommend a MART regime in Frimley under the age of 12. So there's lots of information there. So the real take-home message of that is to make sure their inhaler technique is good, and also to make sure they are using their spacer. If you see a child over the age of 12 or getting towards, you know, secondary school, and they are not adhering to their medicine, we know that in the majority of time, parents don't like giving their children steroid inhalers. So we know that the adherence to asthma medication is poor. So it is, again, explaining to children and to parents why they're taking their inhalers. And actually what I say to children and to parents in clinic, especially when they're symptomatic with asthma and they have got that definitive diagnosis of asthma, that actually, you know, the more you control your asthma in childhood, the less likely you are to use a lot of medication when you're older. And we know that starting well in childhood does definitely have an impact on that adult population and their adult health. So that's what I try and reiterate to parents and make them understand when they come into clinic. But we know that obviously if you're presented with a child who's nearing the age of 12, going to secondary school, they may not be using their spacer and they may not be adhering to their ICS SABA routine. So, you know, consider starting them on a MART regime. And the main one that we've got on our formulary is obviously the Symbicort, 100/6 you would start them with. And that you can start from 12 onwards, you can start on an air regime if they're not symptomatic very often, and then you can go on to obviously a MART regime if their symptoms are more problematic. So that is really the ages between 12 and 17. And then obviously we are looking at producing a primary care pack, which will give information on like a good asthma review to make sure that you include all those modifiable factors for children and young people as well. There is lots of asthma information on the Healthier Together website. This is a really good website for clinicians. It's got an SMS sharing button on the top of every screen. You can press that and you can send it straight to that patient in front of you's mobile phone. So you just add in their mobile phone, and then so you know they've got all of the risk stratification details and a lot of patient information sent straight through to them. We're updating this all the time, and there's lots of information for clinicians and also parents and children. This is part of the risk stratification. So if you're seeing a child who's high risk or intermediate risk, you can actually refer them into the paediatric respiratory team at Frimley Health. So either in Frimley Park, or you can also refer them into Wexham Park as well. And this is really easy to do, and so please do so. We don't accept referrals just for diagnostics, so we wouldn't accept referrals just for spirometry, but we do accept referrals of anyone who's had 1 or 2 courses of oral steroids in the last year, or has had an asthma attack. We're also doing some MDTs with all of the PCNs in Frimley. So this is really work within between the ICB, primary care, and also secondary care. So any of your PCNs can join. We've got 3 at the moment who are on board, and this is a way of improving communication between primary care and secondary care. And what we do is we do quarterly MDTs. We encourage you to do monthly searches, which I'll give you the details on how to do that. I mean, a lot of you are doing the searches anyway, so either on EMIS or System 1, you can do these searches for children who are using more SABA, who may not be picking up their prescriptions of their ICS or their combined inhalers, but also they may have presented to secondary care, or they may have presented to you in primary care. And it's a way of looking at those children before they need to go into hospital and seeing if, what other modifiable factors can we look at? Is there any way that we can help each other? And so it's a real collaboration. My email address is on the end of this presentation, so please contact me, and I can add you to the PCN's MDTs, which are really beneficial. So that's again about the implementation of the MDTs. So it's all about just getting that information out to any clinician actually doing children and young people's asthma reviews. These are the searches that you can find on, this is on Beat Asthma. So these are the searches, and this is really to improve, and it's almost like a risk stratification. So you're finding those children with the high use SABA and also the low dose of ICS that they're picking up. It's also to find the ones that have come in, or the ones who are on oral prednisolone or have had a course of oral prednisolone in the last 12 months. So they are really good and we really encourage all practices to actually do this on children with a diagnosis and children without a diagnosis of asthma as well. So we can really kind of risk stratify all of the children and young people in your surgery and find, you know, and then these might be the children who don't turn up for their annual review. So we want to find those children so that we can give them that education. This is also come about from the NRAD study. It was found that a lot of people who were actually doing asthma reviews didn't have the capability of actually doing it. So making sure that you're working within your capabilities. There's this is some training that's free, it's online, and it's really good training for asthma, for children and young people's asthma symptoms, and also with clinicians who are doing asthma reviews, we say you should be at least level 3. Level tiers 1 to 3 are all free. You just need to register with eLearning for Health, and also tiers 4 to 5 are cost, but I think tier 4 is £480 and it takes 6 months to do. And if you have a practice nurse, or if you're a practice nurse or a GP seeing children with asthma, then we really recommend you doing at least up to tier 4. But tier 3 is free, so we know that obviously that's more kind of like accessible. This is some of the things that we're doing as well around Frimley. So we've got a lot of the asthma youth champions. So we've got a lot of patients now who are on board, who are giving advice as to what they found useful with their asthma and what they didn't find useful with their asthma, and what we would like to change. We're also working with schools. So this is sent out. This is part of the secondary school, a secondary carer running this, the asthma team there. So we have contacted every single school in Frimley, and we know that obviously the majority of children do attend school. So it's a way of giving schools all the resources to actually say, if you've got a child who's at school who's using their blue inhaler more than 3 times a week, then this, you know, we give them resources so that they can send these letters out to their parents to say they need an asthma review, and they need to, you know, their asthma doesn't seem to be well controlled. But we do a lot of other things as well. We do webinars for the school. We get the schools to come in and do training so that there's an asthma champion in the school. We make sure all the asthma medication is accessible, and when to send children home, and when to to look at that child, when to get the school nursing team involved, and also the asthma team at Frimley. We're also working with some of the councils to do work around children living in damp homes. So these are homes that are poorly insulated, and we know that have damp and mould. And if any of you are in the Slough area, we've done a pilot in Slough with this, and we do now have direct access to Slough housing team. So if you want to email me, I can send you on the details of that. But we are rolling this out. This is going to Rushmore actually soon, hopefully, as well. These are webinars that we do. So I've sent all of your PCNs a poster of this, but if you haven't got one, then please ask me and I can send you another one. We can always, these are just general webinars. We changed the ethos remains the same of good asthma care, and then we change it every month in regard to the season or things that are going on. So I've just done one this week on summer health and how to really keep your asthma under control during the summer. So yeah, please do share these with your families, and that would be great, because the more the merrier to sign up for these. We also have an asthma network. So this is my email address. If you want to be part, I send out these asthma bite-sized webinars, emails that have got lots of information about children and young people's asthma. So please sign up for the webinars. Just send me an email to say that you would like to, and please click on the QR code and give me some feedback. Anything that you would like to know about children and young people's asthma care, we can do some professional webinars as well. So thank you for listening, and take care.